Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will talk about inhaled foreign body or anesthetic consideration for inhaled foreign body. Foreign body, inhalation of foreign body can present it either as acute airway obstruction, and this is emergency, or as lower airway obstruction, which develop over several days. Today, we will discuss 3 different case scenarios with different clinical presentation. We will discuss case came as urgent with upper airway obstruction, and the other scenario with lower airway obstruction, which developed over days, and the other a case between these 2 cases. We will know what is the degree of urgency of each case scenario and how to manage them. What are the foreign bodies and where do they end up? What happened next after foreign body inhalation? What investigation should be performed and what urgency of intervention is indicated, and how should you manage the full stomach in all these 3 cases? What staff should be involved and what equipment is required? Should IV access be secured prior to induction of anesthesia or not? And which drug should be considered for induction of anesthesia for these patients? What are the potential intraoperative complications and how to conduct anesthesia for these patients? We will know also what if foreign body dislodged in the trachea during removal, how to manage this scenario. What post-operative care instruction are recommended. All this will be discussed in our lecture today, so stay tuned. First, adult and children can present following the inhalation of foreign body. In young children, this is the commonest indication for bronchoscopy and one of the leading cause of this. In the adult patient can recall the event and diagnosis is more confident, but this is completely different in children. This is more difficult, often relying on history, careful taking history, symptom, and the most important is high index of suspicion. Typically between the age 1 to 4 years, old children are crawling and starting to walk and often put object in their mouth, nose, and ear. What happened next after for inhalation of foreign body? What happened next depends on the size, nature of the material inhaled, and where it stops. If the foreign body is large and causing complete obstruction of the glottis or trachea, unless immediate action is taken, the child will die from asphyxia at home. But if partial airway obstruction occurs, various degree of compromise and urgency depend on size of foreign body and its material and where it stops. Why we concentrate on the type or the material of foreign body? Because most commonly inhaled foreign body is nuts, and oil nut or nut oil is irritant and cause irritation of mucosa of trachea or bronchus and lead to edema. So urgency, if there is a partial airway obstruction, depend on size of foreign body, the material, its material, and where it stops. This needs careful assessment, investigation, and the most important is optimal communication between the surgeon taking the foreign body out from the airway and the anesthesiologist managing this shared airway. As we called it, this is a shared airway. The airway is common between us and the ENT surgeon. So let's take the first scenario. Healthy boy, age 6 years old, has seen the GP for the second time in the last week. He had been diagnosed with chest infection 5 days earlier and been started on oral antibiotics. Over the last 5 days, he had developed ways continue to cough intermittently and remain pyrexial. The boy has mentioned to the parents that the coughing has started 10 days ago after he had been eating some peanuts. This is history. This is the first case. Second case scenario is healthy girl, aged 3 years and 10 months old, had persistent cough for the last 24 hours and presented to the casualty department. Weight is present, typically over the right side of the chest. The parent mentioned that she started intermittently coughing after after a children's party the previous day and become worse overnight. She is apyrexic, no fever, respiratory 26 breaths per minute, auto saturation 97% on air, and she looks otherwise well. The third case scenario is 2 years old boy presented to the casualty department with 1 hour history of severe coughing. Started following shocking episode during a meal which the child had been unable to finish. The parent had initially thought the coughing would settle, but over the last hour, it had got worse. See the rapidity of the scenario here. In between period of cough, the child is crying and obviously distressed, short of breathing, respiratory rate of 38 breaths per minute, oxygen saturation 93% on air, and was beginning to develop intercostal and sternal retraction. So this patient is obviously that he is in severe stress. There was no stridor, cyanosis, or aphonia, and he was apyrexic. So is there evidence of inhaled foreign body in these cases? What is the clinical picture or presentation of inhaled foreign body? Most children presented to hospital have partial airway obstruction as a result of foreign body in the bronchus. Present with sudden onset of shocking, followed by coughing, wheezing, hoarseness, and shortness of breathing. Differential diagnosis for these symptom signs include respiratory tract infection, croup, pneumothorax, and asthma. Most foreign bodies are radiolucent and are not seen on chest X-ray, but secondary signs include lobar collapse, consolidation atelectasis, and air trapping. This can be seen on chest X-ray. So let's take a look on our cases and see what is the presentation and what is there any evidence of foreign body inhalation in these cases. In first case, this is the typical description of typical history from a child with late presentation with mucosal irritation, edema, pneumonitis, distal to the obstructions. This patient was treated as respiratory tract infection and asthma, and end up with intractable secondary lower tract infection. This is slow progression. The other case, second case scenario, this is typical for a child or present child who have inhaled a foreign body with diagnosis requiring awareness and some degree of suspicious. As we mentioned, that high index of suspicious is very important. If this patient left alone without any intervention may represent with airway compromisation, obstruction, and infection as the previous case. The third case scenario, here is a rapidly progressive scenario. This is describe a child who had presented with acute partial airway obstruction. This child is in distress. He is unwell and will require urgent management to remove the foreign body. So before going for intervention and how to anesthetize this patient and conduct anesthesia for this patient, we have to know little information about foreign bodies. What are foreign bodies and where do they end up? More than 90% of foreign bodies are organic material, and this is usual food with not being particularly common. Most are found in one of the bronchi, with the majority inhaled into the right main bronchus because of its anatomical position. So what is the effect of foreign body inhalation? Foreign body, as we mentioned, if there is a partial airway obstruction, it can lead to 4 types of obstruction. Bypass valve. At first, when there is no or very little edema, foreign body partially obstruct both inspiration and expiration. But as we can see in this figure, air can move freely in and out throughout around the foreign body. Okay, check valve can develop after a small amount of edema developed. After a little amount of edema being developed, foreign body in lower airway allow air to enter during inhalation, but not allowing exhalation result in emphysema. During inhalation, air can getting in or ingress only, but there is prevention of expiration by the edema. This lead to air trapping and hyperinflation and emphysema. During each expiration, a little amount or tiny amount of air want to escape from around the foreign body. This can lead to air turbulence in airflow and lead to the expiratory wheeze we heard when we auscultate the chest. This is the cause of expiratory wheeze, air turbulence and resistance to expire this air. Once this actually happen in most of the alveoli, leading to air trapping and emphysema. When we're doing chest X-ray, we have to do X-ray to confirm this check valve. We have to do X-ray during inhalation and during exhalation. During inhalation, we will count both lung inflated, but during exhalation, the side with foreign body, we didn't deflate. We will find it hyperinflated, and maybe there will be mediastinal shift to the other side. This is confirmation for foreign body in this, and this check valve mechanism. Ball valve, which is more dangerous, air can be exhaled but not inhaled past the foreign body, resulting in collapse of the bronchopleural segment. After more and more swelling, as this picture, stop valve develops. There is total obstruction causing lung collapse, atelectasis, then pneumonia. These are the 4 types of obstruction developed. Bypass valve at first, check valve after small amount of swelling, ball valve, then after more and more swelling and obstruction, this is stop valve. What investigation should be performed? The principal investigation is a chest X-ray, anteroposterior and lateral view, as we mentioned during inspiration and expiration, and we mentioned what. But in most cases, foreign body will not be seen in chest X-ray because they are organic material and radiolucent. But chest X-ray are still useful and should be done. They provide secondary signs, partial and complete obstructions such as local collapse, consolidation, atelectasis with a stop valve obstruction, or emphysematous gas trapping, as we mentioned, with check valve obstruction. Also, they can give us an idea about significant lobar collapse and gas treatment. All this may lead to mediastinal shift. This secondary find may not be visible within the first 24 hours, and most chest X-ray investigation within the first 24 hours are negative. So fluoroscopy or chest X-ray in inhalation and exhalation may improve the sensitivity of the investigation. As we can see here, this is A is anteroposterior radiography of the chest during inspiration. There is difference in translucency in both sides, especially in the base. But during exhalation, as we can see, this lung deflated, this side deflated, but the left lung, there is an air trapping in the left lung and hyperlucent, and there is emphysema. And as we see, there is a mediastinal shift to the right side caused by this case caused by peanuts in the left mainstem bronchus. Okay. So after doing the X-ray, case 1 is an evidence of an inhaled foreign body is seen with secondary sign of collapse and consolidation. Case 2 give a reasonable history of inhalation and confirmation with inspiratory and expiratory flow may be useful. The child is reasonably stable and the additional confirmation is needed. As we can look at the third case, the positive history, symptom, and sign of sufficient are sufficient to justify general anesthesia and the endoscopic procedure. In this case, the chest X-ray show no collapse, consolidation, or pneumonia. And the decision in all the 3 cases was made to proceed with tracheobronchoscopy under general anesthesia. So, what urgency of intervention is indicated? The urgency depends on the presentation and severity of respiratory distress. If not severe, so we have time to treat symptom as indicated, as treat dehydration, pneumonia with give IV fluid, antibiotic, corticosteroid, inhalational, nebulizer, correct the symptom. If a convincing history severe respiratory distress, cyanosis, and obvious airway obstruction, this should be given 100% oxygen and transferred to the operative theater in preparation for tracheobronchoscopy. Foreign body in larynx or trachea will cause more distress and are associated with higher mortality than those that are usually smaller and pass more distally into the bronchus. As we can see, upper airway obstruction is more difficult and urgent than lower airway obstruction. So, as we, from the data taken before, case 3 is the most urgent with significant respiratory distress and require urgent intervention. How should you manage the full stomach in these cases? As we mentioned, one of them was eating and unable to complete his meal. Ideally, all patients should be fasted for a suitable period. But in reality, when a child has severe respiratory distress and required urgent intervention to remove a foreign body obstruction, this becomes more important than a strict fasting regimen. Imagine patient in emergency room came in stridor, stressed, cyanosed, pale, drowsy. Should you tell him you have to stay fasting for so and so hour? No, this is not reasonable. So in case 1 and 2, an optimal preparation with suitable fasting period should be allowed as this is not life-threatening. and there is time for optimization. But in case 3, this is urgent, and urgent intervention with removal of foreign body is required, and there should be no delay for suitable fasting period. What stuff should be involved? Once there is suspicious of inhaled foreign body, an experienced staff should be involved. When child with severe respiratory distress, senior anesthetist and senior ENT staff should be directly involved with all 3 cases in the operative room. As we mentioned, this is a shared airway. So once you hear shared airway, this is urgent that most expert staff involved in this case. What equipment required? I should prepare difficult airway trolley, prepare all emergency equipment and all resuscitation drug and emergency drug, prepare suction devices. Familiarity with rigid ventilating bronchoscopy, their attachment and preoperative checks to ensure they are correct and working, this is crucial. Some bronchoscopy, as in this picture, allow the attachment of TPs to the side arm of the bronchoscopy through which oxygen and volatile agent can pass directly into distal trachea. This acts as uncuffed endotracheal tube, act as the same manner as uncuffed endotracheal tube. Oxygen and volatile can be passed directly to the distal trachea. Some bronchoscopy don't allow for this TBs attachment. Therefore, insufflation or intravenous anesthetic technique are used. Monitoring, as regard monitoring, as a stand monitor. Temperature, end-tidal CO2, oxygen saturation, ECG, non-invasive blood pressure, the 5 as a standard. Should IV access be secured prior to induction of anesthesia? The answer is yes. IV access should be established before any operative intervention. This can be done by local anesthetic such as imlacrim or amitob may be tolerated, and after taking suitable time for action, maybe up to 1 hour, IV access can be established. But in urgent situation, with severe respiratory distress, there is no adequate time for topical local anesthetic to work. Also, the child may become too distressed by attempt IV cannulation, so it is reasonable and more sensible to attempt IV cannulation after inhalational induction of these cases. Which drug should be considered? We should consider many drugs during foreign body inhalation. First, anticholinergic drugs. In the past, they were routinely described, particularly with the use of hallucin to reduce associated vagal-mediated bradycardia and reflex bronchoconstriction and a lot of secretion with hallucin. With the more widespread use of sevoflurane, anticholinergic are not always used. If we use anticholinergic, we can use atropine 20 mic per kg IM, 30-minute preoperative, or 10 mic per kg IV at induction, or maybe using glycopyrrolate 5 mic per kg IM or IV. This helps reduce secretion and reflex bradycardia associated with airway instrumentation. Steroids. Although its efficacy is uncertain, but dexamethasone is often administered to reduce post-operative swelling and laryngeal edema following surgical instrumentation during removal of the foreign body. If bronchoscopy is traumatic, we can give dexamethasone at dose 0.25 milligram per kilogram IV, then post-operative give 2 doses, 8 hours in between, of 0.125 milligram per kilogram. We will give steroid for the 3 cases, case 1, case 2, case 3. Here is the most important drug should be given is the local anesthetic, topicalization of the airway. We should topicalize local anesthetic lidocaine 4% up to 3 milligram per kilogram to be administered by spray to the vocal cord and trachea. Topicalization of airway is very important. It reduces the reflex response and cardiovascular stimulation associated with introduction of metal instrument into the trachea. Sedative. Here is the most important and most risky, as you can see, this is dangerous. Sedative drug. Most anesthetists don't give sedative pre-medication, and this is the most important, is not to give sedation for any child with severe respiratory distress. Because if you give sedation, the sedative pre-medication to a child with severe respiratory or with respiratory, it's not severe only, to any respiratory distress, this can lead to unpredicted response with over-sedation, worsening of airway obstruction, and even total airway obstruction. So, most anesthetists don't give sedative pre-medication and they rely on the presence of parents during induction to keep the child calm. So pre-medication was not given to the 3 cases because the risk of total airway obstruction. This is forbidden. So how to conduct anesthesia for this patient? Induction of anesthesia. This is the most important in our lecture today, how to conduct induction of anesthesia. Traditionally, the general principle around induction and maintenance of anesthesia is to maintain spontaneous ventilation with inhalation induction using 100% oxygen with sevoflurane. This reducing the chance for the foreign body to be pushed distally into the airway, because dislodgement of inhaled foreign body can convert partial airway obstruction to more severe or even complete airway obstruction. Using nitrous is not used because increased risk of associated with gas trapping, as we mentioned before. So it is crucial to maintain spontaneous ventilation using inhalational induction. However, in practice, maintenance of spontaneous ventilation in critically obstructed airway can be extremely difficult to sustain, and intermittent positive pressure ventilation may be needed. Recent trials have shown the efficacy of routine paralysis and positive pressure ventilation with better control of ventilation and little impact on dislodgement of foreign body. But so we have to apply topical anesthesia to the vocal cord, consider drying agent, as we mentioned. Prior to bronchoscopy, we have to maintain airway with face mask or laryngeal mask or LMA. The rigid bronchoscopy, Schwartz bronchoscopy, as we mentioned, has attachment for TBs, and we have to check compatibility before the procedure, as we mentioned before. TIVA is becoming more popular maintenance technique. But for foreign body, this is crucial. For foreign body object in the upper airway, you have to maintain spontaneous ventilation. If trachea pole valve obstruction suspected, intermittent positive pressure ventilation is contraindicated. But if foreign body in the lower airway, then intermittent positive pressure ventilation with muscle relaxant is acceptable, since the object will be pushed distally by the bronchoscope until it can be grasped by forceps. We can give assisted ventilation via TPs or using high-frequency jet ventilation. So the surgeon can use grasping forceps be introduced through the rigid bronchoscopy and remove the foreign body. Close observation and monitoring requires throughout the procedure to ensure prevention of movement, coughing, and laryngospasm, to ensure giving adequate depth of anesthesia and deep plan of anesthesia as judged by movement, pupil size, respiratory rate, and pattern cardiovascular parameter. We can give IV steroid, as we mentioned, to reduce airway edema, may be indicated as dexamethasone, as we mentioned, 0.25 milligram per kilogram IVs in post-operative 2 doses, 8 hours in between. During removal of foreign body, it can be fragmented and pushed further into the airway, become lodged high up at the trachea or glottis. If the foreign body is lodged in the trachea, this is urgent. This is most critical time. It can lead to complete airway obstruction and deterioration, severe deterioration on patient. So if foreign body is lodged in trachea, I have to tell the surgeon either to remove need to be removed, or to remove this foreign body immediately, or if he can't remove it, just put it back down into the bronchus in order to give oxygenation for the patient and stabilize the general condition for the patient, and try to remove it again. So if complete, this is important while anesthetizing patient with inhaled foreign body. You have to put this in your mind. While extracting the foreign body and get complete airway obstruction, you have to tell the surgeon either to remove it immediately. If can't be removed, you have to push it down back down into the bronchus. Muscle relaxation at this critical time may be useful by providing a total relaxed upper airway from which the foreign body is extracted. After removal of foreign body and removal of rigid bronchoscopy, I have to intubate the trachea again to secure the airway and recovery for the patient. And extubation can be done according to cuff leak test. If there is enough air leak around the endotracheal tube, I may extubate the patient. If no enough leaking around the trachea, so transfer patient intubation to high dependency. What are the potential intraoperative complications? Potential intraoperative complication can be due to either inadequate anesthesia, inadequate ventilation, or instrumentation of the airway. Inadequate anesthesia, coughing, movement, dislodgement of foreign body, pneumothorax, regurgitation and aspiration, arrhythmias. Complication due to inadequate ventilation include hypoxia or hypercarbia, which promoting arrhythmias. Instrumentation, traumatize any part of the airway can cause mucosal edema and respiratory distress. After knowing all these complications that may happen intraoperative, what are post-operative care recommended? We recommend to do post-operative chest X-ray, transfer patient to high dependency unit using humidified oxygen, observation for airway edema, giving antibiotic in suspected cases of infection, and consider physiotherapy bronchodilator as indicated. Now I finished management of inhaled foreign body. I hope you enjoy the lecture and thank you. وأتمنى اللي استفاد حاجة من الفيديو إن هو يدعي لي ويدعي لوالدتي بجنات الفردوس الأعلى والمغفرة من الله، وإن ربنا يصلح لنا أحوالنا جميعا يا رب. والسلام عليكم ورحمة الله وبركاته.